You're listening to Medscape's In Discussion series on multiple myeloma, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Joseph Mikhael. Dr. Mikhael is a professor in the Clinical Genomics and Therapeutics Division at the Translational Genomics Research Institute, an affiliate of City of Hope Cancer Center. He is also the Chief Medical Officer of the International Myeloma Foundation. Dr. Mikhael is a consultant hematologist and Director of Myeloma Research at the Honor Health Research Institute, where he conducts Phase 1 clinical trials. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Well, hello and welcome. This is Dr. Joseph Mikhael, and this is Season 2 of the Medscape In Discussion Multiple Myeloma podcast series. Today, we are going to discuss one of my favorite topics, and it is the topic of screening for multiple myeloma. We've specifically entitled the topic, Is it time to screen for multiple myeloma? The answer is no, but why? And I honestly cannot think of anyone on the planet who has a better understanding and appreciation of screening, who has led the largest study ever in screening in multiple myeloma. And that, of course, is Dr. Sigurdur Kristinsson. Sigurdur is a very good friend of mine. Don't hold that against him, but he is a wonderful individual. He comes to us as a professor at the University of Iceland. And as we're going to hear during this podcast, he has led the largest myeloma screening study in the world, the iStopMM project, Iceland Screens, Treats, or Prevents Multiple Myeloma project, where close to 100,000 people are involved in the study. And he'll explain to us what that means. And so he has really been leading the whole world effort in myeloma of understanding the principles of screening and how ultimately we may or may not be screening for multiple myeloma. So Sigurdur, welcome to the Medscape In Discussion Multiple Myeloma podcast.
Thank you so much, Joe, and thank you for this kind introduction, and of course to Medscape for having me. I'm really looking forward to our discussions today.
Yeah, it's a really sort of fun environment to be able to have this free-flowing discussion, and I'm looking forward to listening to you. I'm not saying it to butter you up, my friend, but honestly, I learn so much from you every time we have these kinds of discussions because you have spent so much of your career and time in thinking through this topic. I am very thankful that you have the ability and time to spend with us today. So let me just tee it up a little bit, because I think what happens is sometimes we just assume that, well, myeloma sadly is a disease where the average patient sees their primary care provider 3 times with signs and symptoms consistent with myeloma before the diagnosis is made. Yes, there are those incidentalomas where people may get diagnosed because they had a blood test for another reason or insurance reasons or whatever. But the vast majority of our patients get diagnosed after having symptoms over a long period of time. And it's even longer here in the US in certain populations like African American and Latino Americans. So part of us would naturally think, oh, well, then we should be screening for myeloma. I mean, why don't we just catch it early? Isn't that what we're doing in cancer in general? But of course, we've come to realize that you can't just willy-nilly screen. It has to be done in a very systematic way. And Sigurdur, I wonder if you can share with us a little bit about the principles and the concepts of screening, even before we get into myeloma. And I look, for example, at even myself, honestly, next week I'm going to have a colonoscopy. Sadly, my father died of colon cancer, and so I have colonoscopies more regularly. But long before we knew the best way to do colonoscopies or to screen for colon cancer, we had to have the data to prove it. Same thing with breast cancer and mammography. So maybe you can tell us about what some of those principles are that guide us as we think about screening for any disease, let alone myeloma.
Sure. So you bring up a very important topic. So one thing is to identify a disease when it's already symptomatic. Like in myeloma, people have symptoms on average 6 months before they are diagnosed. But what we are really talking about here is screening asymptomatic individuals. And we know from the literature and other cancers that there is benefit of screening breast cancer, cervical cancer, some say for colon cancer as well. So there's evidence for that. But there are criteria that you should use. So these are called the Wilson and Junkner criteria, were established in the 60s and have been updated once or twice since. So they really pinpoint 10 important points or criteria that a disease and a test and the population should fulfill before you even consider screening for them. Sure, it makes sense. I think it's probably true for all diseases. It's better to diagnose them early rather than late. I mean, it makes sense, but we cannot screen for all diseases all the time. It's ineffective, it costs a lot, and it can cause side effects like testing. There can be invasive procedures, there can be mental health impacts, and so on. So the literature is pretty firm on breast cancer and these other cancers. What they have essentially done is randomized clinical trials. So you randomize from screening to non-screening and you see, does this lead to an improvement in outcome? And then the key is, what is the outcome? Usually the outcome is overall survival. So if you screen, it should lead to an improvement in overall survival. Not just, you find more cases and the few that are diagnosed with the disease sort of get a little bit better prognosis. It should be like a general thing. So I think that's the most important thing. The other thing is just to raise awareness for a disease, like a rare disease like myeloma. You should know the symptoms if you have an individual with, anemia, renal failure, or back pain. Think about myeloma and do the testing. But that's not really screening. That's not what we're talking about today. So I think the Wilson Johnson, this is, I think, what some people are discussing at the moment in myeloma, that we should just go ahead and screen. I think, we will have a little discussion about that today. And, I have my opinion about that. And the literature is something that you really cannot debate or have even opinion on. It's pretty straightforward. But in general, you should do the studies, a randomized clinical trial, check the criteria, Wilson and Johnson. If we show that it's superior to not screening in terms of overall survival, yes, let's screen, but then we have to implement that. But if not, we should definitely not do it.
Yeah, that's extremely helpful. I mean, you brought up so many outstanding points, and I think it's really important for our audience to grasp this, because I know many of us can sometimes almost exchange the words screening and testing. And in many respects, when I think of testing someone, because we do a lot of work, for example, a lot of the work that I do in health disparities and even through the International Myeloma Foundation, we're raising awareness, as you said, of myeloma. We're teaching primary care doctors, if someone has anemia, someone has renal insufficiency, these things, that pain that doesn't make sense, then you test for myeloma. That's not truly screening in the big picture that we're looking at.
Right.
Then you're focused on a sign or a symptom. And secondly, I really like how you brought out a very important point of that we need to do this systematically to see an improvement in survival. It's not just catching more cases. I mean, Dr. Kyle showed to us almost 50 years ago now by, if you will, screening a population near Mayo Clinic in Minnesota, that the precursor to myeloma is inordinately common. And so we have to be particularly careful. Maybe I'm biased here a little bit, Sigurdur, from my Canadian training, where we always trained, like, testing actually can hurt somebody. Here in the US, sometimes we just love to order tests, but there are implications, as you said, psychological implications, cost implications. And also, typically, if a test is either equivocal or positive, it might lead to more testing, and there can be other issues with it. So putting in summary what you've said is we do have principles of screening. And really, if we're going to embark on screening, we have to look at overall survival as being the endpoint if we're going to be able to do this en masse. Now, if only we had a large national screening study of tens of thousands of patients to guide us. So tell us about iStopMM. Like, just walk us through. I mean, I can remember being with you in Scotland, I believe, at an evening event, and you and I and Ola Langren and a few other people were writing on the back of napkins, coming up with this sort of basic concept, but you've taken it to a level that is almost indescribable. But please describe it for us.
And Stephen Harding was a key member there as well. So the idea actually came across in Edinburgh in 2015. And we started the whole concept of screening Icelanders in October 2016. So basically what we did is we invited all Icelanders 40 years and older at the time to participate in this iStopMM study, which, as you said, stands for Iceland Screens, Treats, or Prevents Multiple Myeloma. So we really wanted to screen Icelanders for the precursor and see if we could evaluate the effect of screening. So basically, 52% of the Icelandic population, we are 146,000 that are more than 40 years or older. So 80,742 gave informed consent for screening. So during the next 3 years, we managed to screen 75,422 individuals. The binding site in Birmingham performed the assay, so they did protein electrophoresis and free light chain analysis. So those that would be diagnosed with MGUS, either light chain MGUS or classic MGUS, IgG or M, they were then entered in a randomized clinical trial with 3 arms. Arm 1 is basically the placebo arm, if you will, or the standard of care, which is not screening. So they had MGUS but were not notified. Arm 2 and 3 had MGUS, and we met them in our clinic. We informed them, we tested them, we did bone marrow in some and not the others according to the protocol. So basically the whole concept is comparing arms 2 and 3. Those people have MGUS and they are worked up and followed, compared to arm 1, which do have MGUS, but they are not being actively followed. So if MGUS screening makes sense and improves survival, arms 2 and 3 together should have an improved overall survival compared to arm 1. So this is the primary outcome. We also have secondary outcomes, which is compared to, the number of cases. We're looking at mental health impact. We take that super seriously. So we do a lot of questionnaires and we do biobanking and, all kinds of questionnaires and testing. So that's the whole concept. We are currently around 5 years down on the average or a median follow-up time. So it's still too early to say if the overall survival is different. But we have some very interesting findings still that sort of indicate that it's beneficial, but we haven't reached the primary endpoint yet.
Wow. I mean, just the sheer numbers of it become a little bit overwhelming. I'm helping with coordinating a study here in the U.S., as you know, in the Charlotte, North Carolina region. And our chief objective this year is to screen 1,000 people, let alone 80,000. It's just amazing what you've done. Maybe also you can tell us what is sort of unique about Iceland that allows this to happen the way it does. I mean, I know you have an incredible decode genetics lab. There's sort of a philosophy, I think, among the individuals of Iceland that they would be more willing to participate. And so this is a tremendously positive thing, because I assume that you're going to be able to gain a lot of other sort of genetic information through this. Is there something that predisposes and the like? But by contrast, I'll also ask you, does that mean that we can't apply this to other nations or other countries that don't have the same similar background to the Icelanders? But let's start with what makes Iceland so unique and why this study can therefore be even more powerful.
Iceland is a beautiful country with a fantastic landscape and fantastic people. Secondly, there is a tradition here and sort of the philosophy, if you will, that Icelanders really, really like to participate in science. And if they can sort of contribute to new knowledge, that's very important. This is not only the iStopMM. This is true for the genetic studies, and there are many large epidemiological studies with high participation rate, maybe not quite as high as this one, but still. So when we reached out, we didn't really know, would we have 30,000, 50,000 or 80,000, but it just really exploded. So I meet every single one with MGUS or smoldering myeloma, and they have been donating blood. They are participating in all these. They have t-shirts with the sign of different scientific projects and so on. So I think that's a very important thing here in Iceland, that they want to participate. And also when we ask them that, we need another test, we want to do a bone marrow to evaluate this and that, they don't ask first if it's beneficial to themselves. They really say, if it's important for you and my future kids and grandchildren, then I want to do it. Most people are like that. So I think that's very important.
Philosophy would be quite different here in the United States. So that's really, really remarkable.
Right. But the other thing is that since we are collaborating with other health authorities here and Decode, as you mentioned, we have already a lot of information, clinical information, like every disease that all the 80,000 people have been diagnosed with since the beginning of digitalized era. So we have now every pneumonia, every hyperthyroidism, every colonoscopy, every blood test, every thyroid cholesterol level. We know all this for all 80,000 individuals since like the year 2000. Then we update this twice a year, every cancer and so on. And we also have collaboration with the genetic information. So I think that's a very important, that we do not have to collect all these samples and clinical information ourselves. This is just already in the system. And then I think the most important thing is, what's the external validity of what we see? What's the generalizability? I think then it's important to think that the prevalence of MGUS and myeloma in Iceland is similar to other Western or, predominantly white populations. Survival is similar in myeloma compared to, other populations. Both the germline genetics, which we have looked at, and also the somatic changes that happen in myeloma over time, they are exactly the same here as everyone else. So even if Icelanders themselves, their personalities is different to the rest of the world, I think that's a positive thing. But I have to admit that, when it comes to AMCUS, we are basically the same. But having said that, all the findings that we do, and we put a lot of effort on that. So all the findings that we have that can be validated in other population should be validated. Not everyone can do the randomized clinical trial and do lots of bone marrow, but what can be done, like, changing criteria, prevalence of smoldering, all this needs to be validated. And this is what we are doing. And we have also seen, like in the literature, there's a lot of interest in different cohorts to validate. And everything that we have published that can't be validated has been validated. So no one is finding like strange different things than what we are. So I think in the end, when we have like the final verdict, it's only one verdict of them all. It should be screened for MCUS or not. I think people just have to rely on that this is, generalizable.
Oh, you've raised so many points, and I love the fact, by the way, that it's sort of the nirvana of the medical record that you could have it all integrated into one. I mean, I think that's one of the greatest challenges we face here often in the States is this sort of, bits and pieces kind of information, health information. You have it all integrated, which is wonderful. But I really appreciate your comments about the generalizability, because I have heard very often people say, well, Iceland is a very unique country, genetically speaking. It reflects a small group of white individuals. Can this really be applied? So I think your comments about generalizability is really important. I think of one of the individuals who helped with you, especially in the early days, my former boss, Dr. Brian Dury, would say, he goes, it sounds very simple, but myeloma is myeloma.
That's what he loves to say. Myeloma is myeloma. I love that.
And it's true.
I mean, what we have done is like it has been validated in African American populations in the US, in Bronx, in Israel, in China, in Sweden. So wherever you look, this can be validated, and it should.
Yeah. And I think that the point you make is so important to distinguish between a greater incidence of something doesn't necessarily make the disease different per se in that individual. So as an African-American man, I know I'm at twice the risk of getting myeloma, but it doesn't mean that we can't learn from that. Well, as we come into our last 5 minutes or so here, Sigurdur, I really would love for you to share with us. I know that you said, obviously, the final verdict, should we be screening? Does it save lives, right? Does it improve overall survival? That verdict is not out yet. The jury is still meeting behind closed doors, right? We need more time for that. But in the interim, we've learned a lot of things from your study. And I know it's impossible for you to summarize them in a couple of minutes, but can you give us a couple of highlights of things that we've already learned through iStopMM?
One of the most important findings we had was, since we did bone marrow in every single one in arm 3 of the study, which is about 1,100 individuals, we found that we could evaluate the prevalence of smoldering myeloma, which no one had done before. So we could see that 0.5% of Icelanders 40 years and older have smoldering myeloma. So that was a surprise that smoldering myeloma is so common. And I know you had an episode on smoldering myeloma, so I think that's a key thing. And only 8% of them had high-risk smoldering myeloma that some people claim should be treated. So this proves indirectly that you shouldn't treat everyone with smoldering myeloma. You can't treat 0.5% of the population with chemotherapy. We also have changed the definition of light chain MCUS, which was a bit off. So no one has been really publishing anything about light chain MCUS since the definition paper in the Lancet more than 10 years ago. So hopefully we can start to understand more about that. Also, we found a little bit surprisingly that autoimmune disease is not a risk factor for MCUS and myeloma. I know that a lot of rheumatologists and, internal medicine specialists are screening all their cases of autoimmune disease for MCUS and myeloma, but the hazard rate was actually 1.0. So I think that it proves that you shouldn't look actively for myeloma in everyone with rheumatoid arthritis or SLE and so on. And then I think one of the unpublished findings is the mental health impact. When people gave informed consent, 70,000 of the participants gave us their email address. So we have been sending at least once a year, usually twice a year, questionnaires about anxiety, depression, satisfaction with life, and worries. So just after they gave informed consent, like 5 minutes later, they told us if they were worried and anxious and so on, using these validated questionnaires. And then immediately after we told part of the people they had MCUS, they told us again. And then also the people that do not have MCUS, everyone is answering these questionnaires all the time. My mother and all her friends are doing this, and they send me a text when they have. So we can see that using these validated questionnaires now 5 years later, that we are not causing a mental health crisis in Iceland. So people on average are not more worried, depressed, or anxious, and so on. So I think that's a huge secondary outcome of the study, that you can, if you give them the diagnosis, you tell them the plan, it's not a death sentence. Most people actually with MCUS will never develop myeloma, will never need any treatment. So when you deliver the diagnosis in that fashion and you follow them for years, people are okay.
That's amazing. I mean, so many huge lessons there. I'm particularly interested in the one of the autoimmune disease, by the way, because and I used to be, even back in the day when I was in Canada, I had an MGUS clinic, and it happened to be right next to the rheumatology clinic. And so we would always have these discussions whether or not it was sort of incidentaloma, incidentally found, because these are sort of sicker patients that are getting more tests. So I think that really shed a lot of light. And I think the psychological impact aspect of your study is going to be extremely important going forward. I mean, when we think of the implications of potentially screening literally millions of people here in the US and across the world, I think it's going to be important to have that. Granted, as you said already, the philosophy of thinking is a little bit different in Iceland than it would be in the US. I love when you tell me that you send out a survey that takes almost an hour to fill out and they do it. I mean, we'd be lucky here to get surveys done that take 5 minutes. So it's really remarkable. And I really want to commend you in your leadership and work in not only conceiving of this idea, but really fulfilling it. I think it is going to have a massive implication in the myeloma community. Well, it's hard to believe our time has already gone, Sigurdur, but I want to take a moment to thank you again for your incredible insights today. Major lessons we've learned is understanding the principles of screening, that we have to do it in a very calculated and careful manner with truly the goal of being overall survival, that the iStopMM, Iceland Screens, Treats, or Prevents Multiple Myeloma study has consented over 80,000 individuals, and 5 years in has learned great lessons, but is still waiting for the final verdict, as it were, as to whether or not screening is truly going to save lives. And we hope to have that answer from you within the next couple of years. So I'd like to thank Dr. Sigurdur Kristinsson for joining me today. Thank you all.
Thank you so much for having me.
Oh, it's just a pleasure to have you with you, my friend. And thank you all for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on multiple myeloma. This is Dr. Joseph Mikhael for the Medscape In Discussion Multiple Myeloma podcast. Thanks again so much.
Thanks for listening to Medscape's In Discussion Multiple Myeloma podcast series with our host, Dr. Joseph Mikhael. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on multiple myeloma.